This episode is being brought to you in part by Real-Time CTMS, a leading provider of innovative software solutions for clinical trial research sites, site networks, sponsors, and CROs. Real-time systems allow users to manage complex clinical research processes with powerful, user-friendly interfaces that are revolutionizing how research gets done. To get a free demo, visit the company's website at realtime-ctms.com and fill out one of their contact forms. Hello and welcome to the Note to File podcast, a collection of interviews, best practices, and candid commentary for clinical research sites. I'm your host, Brad Hightower. Our guest this week is Beth Baldys. Beth, as inVibe's head of listening, is responsible for helping clients better understand their key stakeholders through deeper and more thorough listening. In addition to bringing patient voice to the forefront, she also works closely with the team to translate research findings into strategic and actionable insights for clients. Beth is a sociolinguist whose graduate research focused primarily on medical discourse analysis, which she continued to pursue throughout her entire career in market research. She brings more than 10 years of experience, including past work in analyzing doctor-patient communication. Her research has contributed to publications in Pain Medicine, the Journal of Cancer Education, as well as a recent acceptance to the CHEST 2021 annual meeting. I thought this was a really cool conversation. I really appreciate sort of the nuance of the way we communicate with our patients at the site level. So I think this was sort of very enlightening to me in a lot of ways. But in this episode, we discuss the secret language of clinical trials, how to better communicate with research patients, reducing burden for patients, and inVibe's recent acquisition by Thread Research. So without further ado, Beth Baldys. All right, Beth, thank you so much for joining us. I know we've had it's been a long journey to get here with a lot of back and forth, but I'm glad to finally have you on.
Yeah, super appreciate you having me. And yeah, excited for the conversation today.
Where are you located at? Are you in Philadelphia as well?
I'm not. Actually, I was in Philadelphia until about 2 weeks ago, and I just moved to Charlottesville, Virginia.
Okay, right on. Is that like a much of a culture shock, or is it kind of...
No, it's pretty much the same. But I did move. I was in kind of like farmland area and did move into more of like a community. So it's been nice to have more stuff around to do. Nice.
Yeah, I grew up in the country myself. So I feel like even in Oklahoma City, I feel like I'm in the big city, even though it's far from it. But I can relate to you there. All right. Well, I start out just about every episode the same. It's always really fun and interesting to me to kind of hear how people's careers have brought them to the clinical research space. I feel like, without being too presumptuous, too, it looks like yours may be even unique compared to a lot of other people. So I guess kind of just maybe walk us through a little bit about your background and kind of, how you got involved in clinical research.
Yeah, you're totally right. I think maybe a strange journey to get to this point, but I am a linguist by training. So maybe a little different than some other folks you speak to. But my involvement, I would say, in clinical research actually stems from my long-standing interest in medical discourse and communication in the healthcare space. And probably the connection doesn't seem obvious at first, but that's really what drew me to a career in linguistics, and then how I eventually found myself here as part of the clinical research process to some degree. So maybe to provide a little more context, my father's a physician and my mother's a nurse. So healthcare has always been really like a central point or conversation in my life. And I remember this one moment when I was younger. So this will connect back, I promise. But we were at my grandparents' house, and one of my relatives was speaking to my dad, and the conversation was just casual about sports or something like that. And for some reason, it shifted into like a medical issue that my relative was having. And what I noticed was it just wasn't a shift in topic, but what in linguistics we might call a frame shift. So my dad's like total conversational style changed and went into professional doctor mode, his intonation, questioning style. And it just always stood out to me, which then led me to have questions about how does language shape our roles, or how we see ourselves, or how we see the world around us. And that's when I found linguistics as a field of study, particularly medical discourse analysis. So how doctors and patients communicate with one another. And that pretty much hooked me from the start. And that's how I kind of translated that into an applied career of analyzing how doctors and patients communicate in office to better understand gaps or misunderstandings, and how to kind of solve those on both ends in the medical education sense, and then to where I am today, kind of applying that into the clinical research space as well.
So yeah, that's really fascinating to me on a few different levels, and probably some nuance that maybe isn't always appreciated, especially, at the site level in clinical trials. We deal with patients and talk to patients all the time. Mm-hmm. And that can go a lot of different ways depending on, how information is presented, with what tone, or, mm-hmm. In what framing, I guess, is sort of, use your verbiage there. But even to go back from that, something I actually just recently made a post about is, clinical research is so full of like acronyms and initialisms, and we use this like secret language almost. Do you think, and I guess this is maybe a little bit outside the scope of what you study, but do you think that's creates issues even within the industry? I mean, we're trying to create something accessible for patients, but it's not even accessible to us. Even we have troubles communicating sometimes because we jump through. Do you think that's problematic, or is it just sort of the cost of doing business, so to speak, in an industry with so much jargon?
Yeah, I mean, it is jarring to jump into. I know translating from more of like an academic career into this field, it was a lot to process. I think it works in two ways. One, it can be a barrier in a sense. You have to know the language, so to speak, to be able to participate. But it can create an in-group, right? So language can connect people, and having a common language is, one, and it can be like, what in between like your in-group, and how there's a lot of studies about how that creates a positive culture and group identity. But I think for patients, we do see, those acronyms or really technical jargon get in the way. Like we just finished a project where we're simply looking at a flyer used to recruit patients. And when they got to the exclusion criteria, there were some of those acronyms you were referring to, even words that I was kind of surprised at that, maybe naturally to me that I've been in this space so long, I thought, they would understand. And it really acted like they couldn't self-identify that this clinical trial then was for them, which is a problem. And luckily we did the research, and our clients were then able to adjust it.
Yeah, I think we see and feel that at the site level sometimes. If you're talking, I mean, an easy example I could think of recent is dealing with patients with heart failure. Mm-hmm. A lot of the criteria may involve ejection fraction, or EF as it's referred. So, well, if you're talking to a patient, what's your EF? Well, they have no idea what you're talking about, which, again, is you're starting to create more confusion, which I think just starts to turn people off to the whole concept. I mean, are there some maybe simple things people can consider when they're having these conversations with patients at, at the site level? Like, maybe just, again, some easy things they can do to help bridge that gap I mean, it's data you need, but how can you communicate that in a way that's understandable, or do you not? Do you sort of get your data in the back end and engage in a different way? I mean, again, how would you translate that into something practical for a coordinator approaching a patient and participating in a trial?
Yeah, I mean, visuals are incredibly important. Anything you can do to help visualize the content for patients. I forget the actual percentage, but the percent of information patients actually tend to take away from visits and conversations is surprisingly small. So things that they can actually take with them to read later is also incredibly important too, because it is, like you said, it can be this like data dump of information. So anything that you can then give them to refer back to later. And then I've always found a lot of success, especially when I listened to a lot of in-office conversations across different disease states, and really this check for understanding and a frequent base to build out for a patient to have a voice can be important too, because just the natural genre of medical discourse, right? You as the patient, you'll come in the room and you sit and you're silent, right? You usually wait for that medical professional to say something to you. You have to like be asked to be that participant. And I think just building that space then becomes even more important.
Yeah, no, I mean, those are great tips. Do you feel, oftentimes too, a lot of the initial introduction to a trial is through the informed consent process. I just posted the other day about a consent form that was 49 pages long or something like this, and really didn't contain a lot of helpful visuals. A lot of that was just walls of text, Do you see this? I mean, I assume this is a fairly common issue. I mean, do you think that that's pervasive? And if so, again, what direction can we start to move that might make even that part of the process more accessible?
Yeah, I mean, it's really in line with what I've seen. Like you said, just kind of walls and walls of text. And, even in just thinking back to that recent example of the flyer I was mentioning, that like pretty much the whole front page was just text. And they had to scan to figure out, what was important, what was the key information they were supposed to take away. So I really haven't seen too much innovation, I guess, in this area, but I think asking patients is really important, and asking patients how they think we can improve. And I think that's, patient centricity at its best, right? That's how we can better serve patients. It's how we can get more interest in our trials and reduce the burden on them, because, they are living with these conditions, and we want to make the process as easy and smooth as possible.
Yeah, I mean, it's to your point. I think it's oftentimes pretty insane what we ask of patients, not just in terms of coming into the clinic and having blood drawn, getting poked and prodded, and going through various procedures, but also expecting them to understand and sort of be an active part of that process. Because again, I don't think we always do a good job of educating, which again is, I think, super important, specifically in clinical trials, because a patient doesn't need to be in a trial a lot of the times.
Yeah.
And that's not always the case in, perhaps different therapeutic areas, oncology, there may be more urgency. But in a lot of cases, migraine trials, a lot of your run-of-the-mill phase 3 drug trials, there's other stuff on the market patients could be using and not having to go through the trouble of driving, 30 minutes across town, getting childcare, maybe having to take off of work. So again, I find that to be really important as educating them to the point they understand the importance of what they're contributing to, and, just to take better sort of control over their own, I guess, health journey, for lack of a better word. Are there specific, I know you mentioned visuals and things like that. I mean, is there anything else specific that you see that tends to be very engaging? I mean, is we talking paper handouts? Are we talking about incorporating things into more electronic forms through videos or e-diaries, or whatever the case may be? Is there stuff that just seems to be more engaging for patients?
Yeah, I mean, anything that brings the content to life is what I've seen. So visuals are one way to do that. I also think, as you were mentioning, there's so much technology nowadays that is there, a gamification in a sense that could be done, right? Like, especially if it's a lot of content, breaking it up. And I think technology is a way to do that a little easier than, your hard copy type format, but visual incorporation, again, through whatever means possible. And again, I think there are probably ways to make it a little more interactive and fun. And now in our very tech heavy world where we're always on our phone, always clicking, always watching, Instagram reels or something like that, sometimes our attention spans are really small. So chunking it up really does help.
Well, to that end, I mean, is there something the clinical trial industry can learn from those platforms? I mean, I love the concept of gamification. I always have, but I've never really seen it very effectively introduced into the clinical trial process. I mean, if you even want to call it that, at the very lowest level, you see, like you refer to, sort of education checks, or like almost quizzing, patients, but it seems to be in a very sort of perfunctory way. Like it's not gamification. It's more of like inquisition. Right. You know what I mean? So
yeah,
like, are we seeing, or is there something we can take from things like Instagram or TikTok that people love, interacting with? Like, is there room for that, or borrow from that in clinical trials? I mean, again, I haven't seen it. Maybe I'm ignorant to it, but it seems intuitive.
It's not something I've seen, but I even know in our own research, when we have kind of asked patients about their user experience, little things go a long way, like feeling welcomed to a survey, having a more casual tone from the person asking the question, so they don't feel like they're put on the spot. And I think it's small things, but it goes back to like asking patients too, and asking them what they want and the experience they want to feel, rather than us just trying to put our expectations or thoughts on them.
Well, and I think you kind of hit on a point that, again, I've always sort of tried to champion in a way. I feel like my sort of shtick is like clinical trials are too clinical sometimes. Like they're coming in and they feel like they're being, they don't necessarily feel like they're being studied, right? Like they want to feel like they're being an active participant. So sometimes it's just a matter, again, I'm not a linguist, but I feel maybe it is a matter of tone sometimes, and a matter of, obviously you want to effectively and faithfully communicate, all the ICH GCP guidelines that need to be covered, but I feel like you can do so in a way that is more casual and is more, I guess, in a way that's more receptive to the patient. Because we also, we have everyone from doctors to people with no high school education in our trials. And I think, again, a sort of underappreciated skill is to be able to recognize the level of ability or the level of understanding a patient has, and then be able to tailor your conversation to them. Is there, again, that's never, no one teaches that in clinical trials at the site level. Is there, first of all, do you think that's fair to say? And if so, is there something people can do to maybe better recognize and potentially use that to their advantage, so to speak? That sounds like a bad way to say it, but
no, I think it's definitely fair to say, right? And I think there are ways that you can recognize someone's understanding or displayed level of understanding. So some of the things that you'll notice obviously are non-verbal cues, like the nodding, head nodding. But then one thing to, I guess, watch out for would be what we call minimal responses. So those yeses, okays, and what research has shown as repeated minimal responses are actually not a sign of understanding or engagement, but actually lack of understanding.
And again, I think that's probably something every coordinator has seen. Maybe they don't understand it, but you'll go through a consent process with someone and come out of the room and know, like, okay, this patient's not going to make it because just by the way that it's the minimal lack of engagement that takes place. Again, I'm really fascinated by this because I feel like there's a lot of subtlety in it that can go, again, unnoticed if you're not really paying attention. And unfortunately, a lot of people who are having these conversations on the front line, so to speak, is a coordinator who's oftentimes overworked and overburdened and trying to manage a whole bunch of things at the same time. And they may not, again, appreciate the importance of these things. Are there any sort of like generic resources that you might put people on that, again, where can you sort of learn more about how these sorts of things can be implemented? Is there a place? Is there a book? What would you recommend maybe?
Yeah, I think there are a lot of friendly resources, especially in like the medical discourse side of things, from Deborah Tannen, who is a professor at Georgetown and has worked a lot in that space. Same with Heidi Hamilton. And, I think linguistics is probably not a very well-known, I guess, discipline. And just a quick Google of linguistic signs of understanding, and there's a lot of, friendly resources out there. I think as linguists, we want more people to be aware of what we do and the importance of language. So try to be pretty friendly about it. And I also did want to circle back to something you said, because we've recently been asking some patients about their reasons for participating in clinical trials or fears. And some of their fears really are what you were talking about, this feeling like a guinea pig, they don't want to be poked and prodded. They want to know it's safe. They have this general fear, but what really gets them excited is the contributions to the community. So it's, again, all about welcoming and creating that connection, because it's what a lot of people's core motivation is giving back and feeling a part of something.
Yeah, no, and that's another great point, and sometimes something that doesn't happen, even at the site level. I think it's important that we ask that. What are your motivations for participating? You can learn a lot. You can get a lot of insight, because I think you're 100% right. We hear all the time, people are really motivated by the idea of helping, and, there's a lot of altruism there. But again, I think that can easily be sort of wiped away if a patient's not appreciated or the level they need to be spoken to at. And I think it can be tricky. I was, I guess, trained is a very generous word to use, but I was trained at an academic institution. It's where I started clinical trials. And I feel like there was a lot more focus on sort of almost cold objectivity in dealing with patients because, this is scientific. You need to be you don't want to be too friendly. You want to keep everything very superficial, so to speak. But I find the opposite is true if you're looking for successful engagement and retention in these trials. I mean, I think, again, I say this all the time, but like by the end of a trial, I know so much about these patients and they know so much about me. I mean, it becomes a relationship versus a transaction.
Yeah.
And again, I think that's something that a lot of sites and coordinators would benefit from understanding and sort of leaning into. And again, I feel like there was potentially resistance to that idea, especially more academic settings. I mean, do you feel that or notice a difference between, academic settings versus private practices maybe? Like, are there distinctions there that are important to recognize?
I think when we've done some work with academic physicians versus community, you do sometimes see a little more of that shift into the more personal, I guess, tone, breaking down things in more of an educated, like an education type way. But I think, everyone has their own style of communication, so it's hard to say which is best. But I think there are benefits to being able to have a casual conversation. But then also I do know that patients put a lot of trust and faith in their physician and want to feel like their physician knows their stuff, right? And we have seen, at least this is an example that I can think of in the oncology space. We did some research and there tended to be like two very strong in this specific oncology space that we were working in, but two very strong patient types or patient profiles when it all boiled down to it in terms of self-advocacy. The one patient type who very strongly wanted to know all the information, research all the information, come in with their own opinion and their own plan. And this other patient who wanted their doctor to do the education, they wanted that one relationship and they wanted to follow directly those specific physicians' instructions. So different styles work, I think, better for different types of patients.
Yeah, I mean, that makes perfect sense. And I think everyone's going to be well served to be able to try to identify that, I think, up front, because again, I think being able to accommodate their particular style is going to go a long way towards, again, continuing engagement and retention. So I guess tell me a little bit about, you guys are now part of Thread. Is that right?
Correct. We are now part of Thread Research. Our core mission has really stayed the same, which is all about, making listening to patients easier and is a standard part of research, but it has allowed us to kind of expand more into that clinical research space and do more of the types of studies that I was talking about earlier with clinical trial materials, bringing the patient voice into those and even the clinical trial design as well.
Yeah, okay, that's where I was going. So does that line you straight through to helping potentially with design that early on, or is it more the sort of peripheral material? I mean, you guys are involved as early as design, it sounds like.
Yeah. And we've even done work kind of pre-design too, with kind of just helping understand the patient experience or what endpoints kind of matter to them, just to make sure their voice is kind of heard, and then trying to get feedback too on some elements. It doesn't have to be the entire design of the research, but if there are certain elements that our clients want feedback on ahead of time, just making sure that it all looks good from a patient perspective and things are clear as well in materials.
Do you think the movement towards decentralizing clinical trials has any profound effect on these issues? I mean, again, the way in my experience, a lot of our patients, like you said, are very interested in, they sort of fall in with, again, what their doctor, is. They want to do what their doctor says. They trust their doctor. Yeah. And so we see, a lot of our more successful trials tend to be driven by that physician engagement, which maybe it remains to be seen yet, but it feels like as we decentralize, that gets a little bit hairier because the patient could be coming from, a different treating physician, or maybe they're seeing an ad and sort of engaging cold in a way, which I guess that may better capture your other patient profile, the more self-advocating patient. But do you think does it require a different approach, or do you think it affects patient involvement as we decentralize, or is it just a matter of adjusting on the fly as we sort of make those strides?
I think it's going to have to be something we see and monitor and see how it affects it. But I know that, at least from the patients we talk to, having those decentralized elements really does encourage them to participate, especially in conditions where it's hard to get around and physically move. And the excitement that we hear and see for some of these elements is pretty clear. So that's been an exciting thing to see. People who otherwise would have said, this is not something I want to participate in, now get to be a part of that, what we were talking about earlier, that moving forward of science and feel, part of a different community that maybe they weren't a part of before.
Yeah, no, that's true. And again, I do love that, we're able to reach people who otherwise maybe never knew the option existed for these things. So I want to shift gears a little bit. Another thing I really like to ask, people who come on is, what are some tools or resources, maybe something you use in your day to day that just kind of help you do your job better? It doesn't have to be clinical research related necessarily, but, I love hearing, how people, deal with time management or what kind of books they're into that help them sort of be the best, they can be. What are maybe some things you'd share with the audience?
Yeah. So a lot of my, day-to-day is being organized and, staying focused on a sense of all the different projects our company has going on. So there are two things that are incredibly useful, I think, for me and for our entire organization. And they're actually I guess more tech-enabled sources than what I was using before, which was just my own little Excel spreadsheet. But we use Trello and Monday.com. And what I love, I think, about those resources, I can track my projects throughout their life cycle and even step by step. I'm very visual, and they have very visual elements, so I can understand my team's resourcing, project level priority. So all of those things that could otherwise, if they weren't organized, be incredibly overwhelming. And then obviously, part of my job is listening. So a good pair of noise canceling headphones can't live without that.
Nice. Yeah. No, I'm a big music guy, so I love. I'll take any excuse to put headphones on. No, I'm with you. I like Trello a lot. I'm a big fan of Kanban boards and being able to sort of see all that stuff. I struggle with organization, like I have my whole life. So I love having those tools, and those are both. I've used Monday a little bit as well. Those are pretty easily accessible tools that I think even both have free options. For people out there who might be looking at trying those things out. So. Yeah, no, I love that. Anything else before we wrap up? I think this is really fascinating. Again, this is something that's always been under the surface, being cognizant of how we talk to and engage with patients. And I've never really heard anyone talk to that, which maybe that's, again, my own ignorance of not being out there more. But I think I really appreciate that that's, it's a role. Someone's out there specifically looking at that. And I think that's, again, incredibly useful and maybe still sort of undervalued.
I super appreciate that. Language is just so incredibly powerful, but often it really is overlooked because it is such a core part of our day-to-day, our experience. But, when it comes down to it, there's so much really happening behind the scenes when we speak. It's not just the words that we're saying, but how we're saying them in terms of our intonation, our word choice. There's, so many creative ways in which we can make a sentence, but intentional or unintentional, we kind of choose the words that we do. And that really leaves clues about how we see the world and how we interact with the world around us. And I always have found that incredibly fascinating and important to consider as when you can.
Yep. No, I'm with you there. Where can people find you online?
Yep. So I'm on LinkedIn, Elizabeth Baldys. You can also shoot me an email, beth@invibe.co, or check out our inVibe website. There's more information on there about what we do and how we do it.
Awesome. Anything else before we wrap up?
Nothing from me. Just thanks for having me. Super appreciate it.
Yeah. No. Again, I think this is really fascinating. So I appreciate you coming on. And until next time, thanks so much, Beth.
Cool. Thanks.
As always, thank you so much for listening to the Note to File podcast. Make sure that you subscribe, or whatever any of that other fun stuff is, so that we can keep pumping out some podcasts for you guys. Also, make sure to check us out at notetofilepodcast.com. We do our best to post show notes, episode transcripts, as well as contact information for our guests. Thanks again.